I think we're now good to go. We will start now the lecture. Yesterday, we started on this lecture on anatomy of the urinary system. We did not finish, so it is my intention that we are going to do that this morning, and also to start another one that I'll be telling you shortly. But just to highlight on what we did yesterday, we looked at the anatomical and functional components of the urinary system. We also described the external and internal structure of the kidney. We explained the key functions of the kidney. We described the structure of the nephron, and we stated the role of the different parts of the nephron. We also explained the three basic renal processes, which are the mechanisms that underlie urine formation. We explained the endocrine functions of the kidneys. That's where we stopped. So today, we are remaining with two agenda. One is to describe the anatomical components of the urinary passages, and the second one is to describe the development and congenital malformations of the urinary system. We'll start from where we left, where we are going to then talk about anatomical components of the urinary system. So the anatomical components of the urinary system are these ones. We have the collecting ducts. Remember that urine is formed by the nephron. And when urine is formed by the nephron, that urine is delivered to the collecting ducts. So we consider the collecting ducts as the initial component of the urinary passages, in as much as we also consider the collecting duct as part of the nephron. We can consider it as the transition zone anyway. So in terms of collecting urine, then let's start there. So the collecting ducts are within here, within the renal pyramid. Many of them will empty here. Thousands of them will empty here at the renal papilla. And yesterday we agreed that we have about 18 renal papillae corresponding with the number of renal lobes that we do have. So as the collecting ducts open at the renal papillae, they empty into the minor calyx. That means that each minor calyx drains a renal lobe. From the minor calyces, urine goes to the major calyces. We agreed that we have three major calyces: the superior, middle, and inferior major calyx. From the major calyces, urine goes to the renal pelvis. There's one renal pelvis. Now, the minor calyces, major calyces, and the renal pelvis is what we call the pelvocalyceal system yesterday. From the renal pelvis, urine goes to the ureter. At that junction between the renal pelvis and the ureter, there's some level of narrowing. That narrowing between the renal pelvis and the ureter, maybe the narrowing somewhere here, is what is otherwise known as the ureteropelvic junction. The ureteropelvic junction is a common site of urinary obstruction, both congenital and acquired. Okay, now urine goes to the ureter. The ureters have usually described in terms of having two parts. There's a part of the ureter that is within the abdomen. You can call them the abdominal ureter. And there's a part of ureter that is within the pelvis. You can call it the pelvic ureter. Other than the uretero-pelvic junction, the other site of obstruction of the ureter is when the ureters are crossing the pelvic brim. At that point, they may be obstructed. So when the ureters are changing from abdominal ureters to pelvic ureter, where they're crossing the pelvic brim, that's also another site of ureteric obstruction. And finally, the final site of ureteric obstruction is where the ureter is entering the urinary bladder. We call that uretero-vesical junction. So understand those three sites of ureteric obstruction: uretero-pelvic junction, pelvic brim, and uretero-vesical junction. After the uretero-vesical junction, the ureters enter the urinary bladder. The ureters are two, but urinary bladder is one. And from the urinary bladder, we have the urethra. So this shows you the ureters, two of them. Uretero-pelvic junction be there. This is where it's crossing the pelvic brim. And that's the uretero-vesical junction. Okay, down there, sorry. Uretero-vesical junction. That's the urinary bladder, that's the urethra. So those are the urinary passages. Let's say something more about the urinary bladder. We know that a muscular sac that stores urine. Usually, when the urinary bladder is empty, it will be in the pelvis, but when it is full, it can extend into the lower parts of the abdominal cavity, specifically in the hypogastrium, or what we call the suprapubic region. There are three openings within the urinary bladder, two for the ureters and one for the urethra. That triangular region surrounded by the three openings is what we commonly call the bladder trigone. The smooth muscle of the urinary bladder is commonly known as the detrusor muscle. That the smooth muscle of the urinary bladder is known as the detrusor muscle. Now at the neck of the urinary bladder, there's a sphincter which controls bladder output. So we call it the urethral sphincter. In males, the urethra will go straight through the prostate. Of course, in female, that's different. This is what we see in female. There's no prostate, but still the urethra comes out. Let's talk about the nerve supply to the urinary bladder. The bladder receives autonomic supply. So that means both sympathetic as well as parasympathetic. The sympathetic supply to the urinary bladder largely causes bladder wall relaxation and urethral sphincter contraction. Therefore, sympathetic makes you to retain urine, while parasympathetic causes bladder wall contraction and urethral sphincter relaxation. And that means that parasympathetic makes you to void urine. Other than the sphincter controlled by the autonomic nervous system, we know that the urethral sphincter, there's also an external urethral sphincter, which is of skeletal muscle. And that one, you have voluntary control over it. And so the external urethral sphincter is the one that makes us have that conscious control of urinary voiding. Otherwise, we'll not be able to control it consciously. All right, let's say something about the urethra. So this is the urethra in females, and this is the urethra in males. There are quite a number of differences between the two urethrae. I want us to discuss them. But before that, maybe you answer this question. So it's projected on your screen. I want you to use the chat to respond. I'm the only one who will be able to see what you've written. So you just choose either A, B, C, or D on the chat. You have 1 minute for this. Right, 1 minute is over. So I'll close the chat. I'm just scanning through, and people have chosen all the choices. I think the only choice that has not been picked is D, and that's understandable. But it also means that people don't know. Let's see. So in terms of length, definitely the male urethra is longer than the female urethra. In terms of diameter, the female urethra is wider than the male urethra. That's why you can catheterize using a bigger lumen catheter in female, but you can't do that for male. In terms of orientation, the female urethra is more straight. The male urethra is angulated. That angulation is irrespective of the penile physiological state. But if the penis is fallen, then again, it means that there are more angulations. You know, there's angulation between the prostatic urethra and the membranous urethra. Okay, I didn't take you through the parts of the urethra. I'll do that in the next lecture. But the male urethra is angulated. In terms of the site of opening, the male urethra opens externally. You know, the female urethra, you really have to peep for you to see. It's a bit hidden. And then in terms of function, I think this is okay for everyone. That male urethra has reproductive functions in addition to the urinary functions. So those are the differences between male and female urethra. And that actually summarizes what was remaining in terms of the anatomy of the urinary system. So I don't think you really need a break, but perhaps you have a question. I'll give you a chance to ask before we proceed. If there's no question, let's proceed now. We are going to look at embryonic origins and congenital malformations of the urinary system. Let's start with the embryonic origin of the urinary system. I hope you people still remember this thing here. The blue represents ectodermal derivatives, so that is surface ectoderm, this is neurotube. These are the color represent mesodermal derivative, paraxial mesoderm, intermediate mesoderm, lateral plate mesoderm. And that lateral plate mesoderm has splanchnic, sorry, this other side, splanchnic mesoderm and somatic mesoderm. The yellow represents the endoderm, the black is notochord. The urinary system arises from the intermediate mesoderm predominantly. This origin is together with the reproductive system. So we can just say that the urogenital system arises predominantly from the intermediate mesoderm. Generally, most of these structures will be formed along the posterior abdominal wall. So the kidneys will be along the posterior abdominal wall. The ureters will be along the posterior abdominal wall. Right. Now, prenatally, there are 3 kidney systems that are present. There are 3 sets of kidneys that develop prenatally. We call them the prenatal kidney systems. The first kidney system are known as the pronephros. The pronephros are represented by about 7 nephrons, which appear within the neck region. So in the cervical segment, these pronephros, even though I'm calling them nephrons, they lack the renal corpuscle. And for that reason, they do not have the capacity for forming urine. They are non-functional. So remember, they form in the neck region. They're about 7, but they're non-functional. That means that they can't form urine. They appear around the 4th week of development. And by the 5th week of development, they have already disappeared. So they only last for about a week or about 10 days or so. Then they are followed by what we call the mesonephros. The mesonephros are about 40 nephrons. These mesonephros form within the thoracic and lumbar segments of the fetus. They appear around the end of the 4th week or beginning of the 5th week, and they last until the end of the 2nd month of development, which means around the end of the 8th week, end of 9th week there. They are functional because they have renal corpuscles, so they form urine. So mesonephros are really many, about 40 of them, thoracic and lumbar region. Remember that. Remember, they are functional, they form urine. The duct of the mesonephros is this one. We call it the mesonephric duct, or otherwise known as the Wolffian duct. That duct of the mesonephros empty its urine into the cloaca. The cloaca is a common chamber for the allantois as well as the gut. The gut, remember, is the lumen of the yolk sac. And then the allantois is that one. So this is the cloaca. The mesonephric duct empty its urine into the cloaca. Even though the mesonephros are functional, they also disappear. By the time we are in the 9th week of development, we do not have the mesonephros. Instead, we have the third kidney system, which we call the metanephros. The metanephros appear in the pelvis. Now, not in the neck, not in the thorax, not in the abdomen, but in the pelvis. These metanephros are the ones that contribute to formation of the final kidney, what we call the permanent kidney, the kidney you and I have. So those are the three kidney systems. Now let's talk about how the permanent kidney is formed. The permanent kidney, or the definitive kidney, is the kidney you and I have. This permanent kidney is formed in the pelvic cavity. You may not believe that for now, but it forms in the pelvic cavity. At some point, your kidney was in your pelvis. But the final kidney develops from two sources, and I want you to understand this. It develops from what we call the metanephric blastema. The metanephric blastema is a compact cellular mass which is formed by the metanephros that we've just talked about. Compact cellular mass formed by the metanephros. This compact cellular mass contributes to formation of the urine-forming structures. Yesterday, we agreed on that term, urine-forming structures, or otherwise known as the secretory units of the kidney. And that basically refers to the nephrons. The metanephric blastema differentiate into the nephrons. We have about 2 million nephrons in each kidney. But it forms as a compact mass within the pelvis. The second structure that contributes to formation of the definitive kidney is what we call the ureteric bud. The ureteric bud is the diverticulum from the mesonephric duct. I told you that the mesonephric duct is the duct of the mesonephros. So that's the duct of the mesonephros into the cloaca. There's a diverticulum from the mesonephric duct, which contribute to formation of the kidney. Maybe this is a better image to show you that concept. So this is the mesonephric duct, this blue one, the thin one, up to the cloaca. That yellow one is the ureteric bud, and this black one is the metanephric blastema, a compact mass of the metanephros that will give you the nephrons. The yellow one is the ureteric bud. The ureteric bud contributes to formation of the urine collecting structures. And that means that the ureteric bud will then differentiate and divide progressively as it enters this kidney. And so it will give you the ureter. Now we can follow that proximally. After ureter, we go to renal pelvis, major calyces, minor calyces, and finally, the collecting ducts. All those come from the ureteric bud. Now, you need to understand, therefore, that the nephrons, which are differentiated from the metanephric tissue, must then establish communication with the derivatives of the ureteric bud at the collecting ducts, so that now urine can move from the nephrons to the collecting ducts. Now that our kidney formed in the pelvis, there must be an event where the kidney then changes position. It will have to migrate from the pelvic region. It will have to migrate to the abdomen. These yellow things show you the location of the suprarenal gland in the fetus. That is where they are initially. The kidneys are the ones which migrate upwards to join them. So you can see at this point, the kidneys are here. At this point, the kidneys are moving. At this point, the kidneys have reached somewhere there. And here, the kidneys have reached up. Well, at the same time, the gonads are also descending, but we'll talk about that later when we look at the reproductive system development. For now, we are focusing on the kidneys. The kidneys ascend. What I want to picture in this journey of ascent of the kidney is how the blood vessels that supply the kidney change. So initially, the kidneys are supplied from these arteries here, common iliac arteries. But as the kidneys go up, they change the blood supply. The predominant renal artery is no longer from the common iliac, but this segmental artery is here. And when they reach up, the predominant arteries are even much higher. So the renal arteries are up there. But that means that these other vessels may refuse to involute. And so we are going to see what it causes if that happens. Message here is that the kidneys ascend from the pelvis to the lumbar regions of the abdomen. Let's say something about the cloaca. So this is a cloaca. The cloaca is a common union for both the hindgut as well as the allantois. Remember, the hindgut represents the lower part of the alimentary canal, specifically the region around the descending colon, sigmoid colon, and the rectum. While the allantois, we talked about allantois as partly involuting and partly being incorporated into the urinary bladder. So at some point, the cloaca is just a common union. That means that it represents communication between urinary system and the digestive system. And indeed, in humans, at some point, the two are communicating. In some animals, like the reptiles and the birds, the story ends there. They actually do have a cloaca. That's why you may not see your chicken at home urinate and then pass stool separately like humans. It's just one chamber. But in mammals, this is different. The cloaca is partitioned. So the cloaca undergoes partitioning. There's a tissue of mesenchyme that splits the cloaca in a coronal section into two. This is the tissue, we call it urorectal septum. And we see it here going down to split the cloaca. And here it has split the cloaca completely into two. When the cloaca is split into two, the anterior component of the cloaca is known as the urogenital sinus. This urogenital sinus will give rise to various derivatives of the urinary and reproductive system. That's how we call the urogenital sinus. So what does it give us? Remember, it was partly part of the allantois. So it will give us the urinary bladder. This segment will give us urinary bladder. This lower segment will give us the urethra. Partly it will give us the vagina and derivatives that will give you the prostate gland. But let's ignore the components of the reproductive system for now. So the component of the urinary system that comes from the urogenital sinus is urinary bladder and urethra. This other part of the urogenital sinus, the allantois, as we mentioned last time in previous trimester, that part involutes. It forms what you call the urethers that will become a median umbilical ligament. So allantois becomes urethers, which becomes a ligament, but this part forms the bladder. The posterior component of the cloaca give us what we call the anorectal canal. The anorectal canal form the anus from the rectum, as the name suggests. Right, so those are that's the cloaca and its derivatives. Now I want us to look at congenital malformations of the urinary system. We can start with those congenital anomalies that are related to renal growth. I want you to look at that image and tell me what you see. So this I'll give to, let me start from below today. So Vincent, we'll start with you. Look at that image and tell me, what do you think is a problem on that kidney system?
Is it the pair of kidney? Because there is one that looks like it's fully formed, and there is one that seems to be not fully formed.
Yes. Great, that's okay. So that's what we call renal hypoplasia. It means underdevelopment of the kidney, as Vincent has just told us. So when you have renal hypoplasia, if it is bilateral, then it may be clinically significant. If it is unilateral, like in this patient, it may not be clinically significant. And so sometimes someone may not know. That's renal hypoplasia, underdevelopment of the kidney. Okay, Tribian, this is yours. Look at those two kidneys and tell me, what do you think is a problem with those two kidneys?
Can it be polycystic kidneys?
Not quite, not quite. What do you see on the surface of the kidney?
There are some whitish things.
Okay, the whitish ones are normal. That's fat. We also see it here. What else do you see on the surface apart from the fat tissue?
The kidney is not well, it has some, what can I say now?
Okay, the vocabulary has disappeared, but I know you understand.
Yeah.
We call this lobulation. The lobes are there. You see, in as much as we said that we have about 18 lobes, those lobes usually you don't see them on the surface of the kidney. In human kidney, you don't see them. In other animals, but they like cows, you'll actually see them. But in human kidney, the surface is actually smooth, like the first one there. So here we see those grooves which show us that this is one lobe, that's another lobe, that's another lobe. So we call this one persistent fetal lobulation. In terms of function, nothing much really. So you may not know that you have it because the kidney is still functional. Right, so this goes to who now? This goes to Shelo. Shelmith, you're in?
Yes, I'm in.
Okay, Shelo, look at that image. Okay, give me a second, I connect my power. Okay, we are good. Shelo, look at that image and tell me, what's the problem with the renal system in that image?
There seems to be one kidney on one side and the other side it's absent.
Great. So one kidney is not there. This is one kidney, the other side is not there. This is the spleen, that's the stomach. So we call this renal agenesis. So renal agenesis means that one kidney has not formed. If you have bilateral renal agenesis, it may not be compatible with life. But unilateral renal agenesis is compatible with life. Someone can survive without one kidney, but you cannot survive without both kidneys unless now you do dialysis. Okay, so this one goes to Nema. Nema, you with us?
Yes.
Okay, look at that one. Tell us, what do you see in that kidney?
It has a lot of fatty tissues.
Apart from that?
The surface of the kidney is not continuous like the normal kidney.
Yeah, what do you see on the surface?
It has some things like cyst on top.
Yes, it has cysts, okay? Now that is what we call multicystic kidney disease or polycystic kidney. Well, in terms of diagnosis, they have different meanings, but radiologically and morphologically, let's just call them multicystic kidney. Kidney with multiple cysts. Usually this could be because there are some nephrons that did not establish communication with the collecting ducts. And so they form urine, but the urine does not go anywhere. So they remain as cysts. They form polypoly. Just some, by the way. You don't have to have all the 2 million. Maybe even just 1,000 only, but they'll form cysts still. Okay, so those are anomalies related to renal growth. Then we have, yes.
Is for the first anomaly, the renal hypoplasia. Let's say we have both of them, not fully formed. Can the kid survive?
It will depend on the level of hypoplasia. You know, you can just have hypoplasia with 50% function, 10% function, 0% function. So it will depend on the level of the hypoplasia.
Thank you.
If it is severe hypoplasia with 0% function, then it means that there'll be no postnatal survival. So,
thank you.
Okay, then we have malformations, which are related to renal ascent. We've agreed that the kidney needs to migrate from the pelvis to reach the abdomen. So there's some malformations which are related to that journey of migration. Okay, Mary, we'll start with you. What do you see on the first image? Mary, can you see something?
Yes.
Yeah, what is in the first image?
I can see the left kidney. It's on the lumbar region, while the right kidney is just below the pelvis.
At which region is this? So I'm pointing at the one of
The
the
left.
Okay. So let me just guide you there. The kidney I'm pointing at, radiologically, when you look at these images, you assume it is the patient facing you.
Yeah.
And so this is the right side of the patient.
Yeah.
This is the left side of the patient. So this is the right kidney. This is the left kidney. This is the liver. This dark region means air. So that is lung. This bright thing, that is contrast within a blood vessel. That's aorta. Okay, so tell us, between the right and the left kidney, which one has a problem? Mary, which one?
The left. The
The
left.
left kidney has a problem. What's the problem with the left kidney?
It's in the thorax region.
It is in the thorax. That's the problem. So this one has over-migrated. You can call it thoracic kidney. Okay. Right. So Joyce is next. Jess, you're with us?
Yes, I am.
Okay. What's the problem with the kidney on the second image?
I can only see one kidney in the pelvic region.
Great. So there are two problems there. That first, we have renal agenesis. So one kidney is not there. And the one that is present is in the pelvis. So we call that pelvic kidney, in addition to the renal agenesis. Good, I'm glad you've picked both of them. So now we have John. John, you're with us?
Yes.
The third one is yours. What's the problem with the kidney system on the third image?
Both kidney are in the same side.
Great. So it means that one kidney crossed the midline. So we call that crossed renal ectopia. One kidney crossed the midline. So John, which kidney crossed the midline here? The right or the left kidney? John, back to you.
The left one.
Yes, the left one is the one that has crossed the midline. It has gone to the right. Right. James, the last one is yours. You're with us?
Yes, I'm in.
Okay. What's the problem with the last kidney?
The two kidneys did not separate. They are united at the center.
Great. So the two kidneys are fused. Now, when the two kidneys are fused, they usually fuse in the pelvis. And if they fuse in the pelvis, they will be unable to ascend all the way up to the abdomen because of the origin of the inferior mesenteric artery that arises from the aorta, and then it's an anterior branch. So usually the artery will hold the two kidneys down. The two kidneys which are fused cannot ascend to the abdomen fully. And that's why we are classifying it under this one. We call this one horseshoe kidney, because it looks like the foot of a horse. Two kidneys which are fused in the pelvis, they cannot ascend to the abdomen because they're held down by the inferior mesenteric artery. Those are malformations of renal ascent. Then we have this entity, anomalies related to ureteral bud. We've agreed that the permanent kidney arises from two sources, the metanephric tissue and the ureteral diverticulum or the uretral bud. So malformations related to the differentiation of the uretral bud. Florence, the first one is yours. What do you see? Florence, can you see something?
Yes, I'm trying to think.
Okay, what do you see in the first image? So remember, we are looking at the urine collecting structures. Those are the derivatives of the ureteral bud.
You can see a bladder in the pelvic.
Okay. A bladder in the pelvis is a normal thing, Florence. See,
Let me answer now.
See, we all have urinary blood in the pelvis. Florence, I'll guide you.
Okay.
So what do you think is this?
I think I cannot see.
Okay. What do you
I
think?
can't see the image.
What do you think this bright thing?
I'm not able to see a pointer.
Oh, okay. Let me give it to someone else then. Okay, so I'll give it to Faisal. Faisal, can you see?
Yes.
Okay. Faisal, what do you think is the problem with the first image? Can you see the problem?
The two kidneys are, can you say closer to the midline?
That one is normal. I want you to remember, Faisal, our title here is Malformations that are affecting the ureteral bud. I've told you that the ureteral bud gives you the urine collecting structures. Ureters, renal pelvis, major calyces, minor calyces, collecting ducts. I want you to look at the urine collecting structures. The urinary passages is the problem here, not the kidney itself. Now, so look at
on the left kidney. There are two ureters living.
Yes, you see two ureters there.
Yeah.
Good. So we call that a duplex collecting system. When you have double collecting system, we call it duplex collecting system. So this is the same patient, by the way. The first one and the second image, these are the same patient. When you have a duplex collecting system, one of the ureters may end up with a ureterocele down there, which can cause urinary obstruction. Okay. So now we go to Eric. Eric, you're with us?
Yes, please.
Okay. Eric, the third image here has a problem. What's the problem?
I think there's a constriction on the ureters, on the ureter, so urine cannot pass.
At what point?
At the ureteropelvic junction.
Good. So we call this ureteropelvic junction obstruction. Great. So that's also a congenital anomaly. Dana, are you with us?
Yes.
Okay, Dana, the last one is yours. It's a bit hard though, but try. What is the problem?
The ureter of the left kidney is coiled.
Yeah, it is coiled. I agree with you. What else is abnormal about it apart from coiling? And we can use the term tortuous instead of coiling. So the ureter on the left is tortuous. What else is wrong about it?
Several lobules.
Maybe not lobule. Comment on the size. Compare this size and that size, or compare the size possible size that we would have expected on the right with possible size that we're seeing on the left. What did you say?
Hypertrophied.
Okay, maybe dilated. If you have a luminous structure, then we don't necessarily talk about hypertrophy. It's dilatation, so it's enlarged. So the left ureter is dilated and tortuous. There is hydronephrosis, and it's also tortuous. We call this megaureter. If there is no anatomical constriction, we call it megaureter. Okay, then there are malformations that are related to vascular development. I'm not so sure whether you'll be able to pick these ones. Yeah, you should be able to pick the first two. Maybe the last two will help you people. Daniel, the first two are yours. This and this show you the same clinical entity. What do you think is the problem here?
Hello.
Yes,
I'm able to see two ureters. There are three.
They're not ureters. On the first image,
the first image
is the ureter. So the ureter is just one. What are these?
The positioning of the ureter.
Not quite. Okay, what are these? What is this structure here? This big one, what is it? What do you think? Daniel, any idea? Okay, anyone to try this one?
The abdominal aorta.
Yes, so this is the aorta. That means that these are renal arteries. So you have accessory renal arteries. Even this is the abdominal aorta, so these are renal arteries. So there are multiple renal arteries going to the kidneys. We call that accessory renal artery. When a patient has accessory renal artery, they don't become a good candidate for renal donor. They're not good candidates for renal donation. And that's why sometimes when you want to do renal donation, we have to evaluate both the recipient as well as the donor kidney to see whether the donor is appropriate for donation. This other one might be a bit hard, so let me guide you.
I have a question.
Yes, Anne.
So will they survive with these two renal arteries, or at some point will it compromise the action of the kidneys?
Actually, they don't. You might be surprised that 50% of us have accessory renal arteries. So it doesn't compromise on function. It doesn't at all. The only problem is that now if you may not be able to use that kidney for donation, because when you have an accessory renal artery, sometimes those two arteries are supplying regions of the kidney which are very independent in terms of function. There is no anastomosis. Now, if you take it to a patient who has only one renal artery, which vessel are you going to connect? Whichever vessel you connect, the one that you don't connect, that region may undergo ischemia, might die. That's why they're not good donors. But as long as it is within the same patient, the same patient where the kidney came from, there's no big deal. So,
okay, thank you.
So in this patient, a bit hard for you, but let's look at the left kidney. The left kidney is normal. This is the ureter. The ureter usually come down like that. On the right kidney, the ureter should come down like this. But in this case, we see the ureter going behind the inferior vena cava before it goes down. And that's the problem. If the ureter goes behind the inferior vena cava, we call that retrocaval ureter. Ureter behind inferior vena cava, retrocaval ureter. If you have retrocaval ureter, that ureter may be constricted again. That will what will cause hydronephrosis, as you can see in this image and depicted on that patient as well. There are malformations related to development of the urinary bladder. So in the first image, Collins, what do you see? Collins?
I can't pick anything, Mwalimu.
Okay, I can guide you. So this is the urinary bladder.
Yes.
The anterior wall of the urinary bladder is not there. So we are just seeing the mucosa of the posterior wall of the urinary bladder exposed. Okay. Do you know how this anomaly is called?
No.
Okay.
I don't, not unless I do some research.
No problem, no problem. Anyone who knows the name of this anomaly? It is the most severe form of bladder malformation. At this point, hakuna mwenye anafanya kazi kwa pediatric surgical unit. Okay, James, yes.
It's called bladder extrophy.
Great. This is bladder extrophy, the most severe form of urinary bladder malformation. We'll revisit that when you look at reproductive system as well. As you can see in this patient, the external genitalia also has an issue. You may not believe that it's a male child. Okay, on the left, we see urinary bladder with some diverticulum. And so we call this bladder diverticulum. Okay, then we have malformations related to development of the urethras. Remember, the urethras is a remnant of the allantois that is supposed to then involute. So in this first one, the urethras is persistent completely. And what do you want to call this one, where the urethras is persistent completely?
I've forgotten the name.
Okay, when you have an abdominal tract connecting two surfaces, what do you call it?
Fistula.
Fistula, good. So this is urethral fistula. Okay, sister, so the second one is yours. Here, the urethras involuted on the lower end, but the upper end of the urethras persisted. So you have a tract with a blind end coming from the umbilicus. What do you call this, sister? Sister, you are muted.
Sorry, come again, I had lost.
Okay, what do you call this anomaly here, where we have a tract with a blind end arising from the umbilicus?
Atresia?
Not quite, not atresia. You know, you use the term atresia. If something was supposed to be there, then it's blocked, then that is atresia. Here, it's an abnormal tract with a blind end.
Well, I have no idea.
Okay, I'll guide you on this one, then you'll give me the name for the second one. So this is what you call a sinus. can call it urethral sinus or umbilical sinus. Okay, this one we've already talked about, that's bladder diverticulum. Sister, give me the name of the last one. You have a collection without an opening along the urethus.
Urethral cyst.
Urethral cyst. So this is urethral cyst. Great. So those are anomalies related to urethral development. Then we can have anomalies related to development of the urethra. In the first one, very common, we see this is urinary bladder. Then this is the initial segment of the urethra, but thereafter we don't see the outline. So the proximal urethra is dilated and the distal part constricted. It means that there's something causing blockage of the urethra there. This is what we call posterior urethral valves. We see this in male child. They present with urinary tract obstruction. In the second one, we see a rectum opening into the urinary bladder, to the urethra, opening to the urethra. So we call that urorectal fistula. Of course, this is together with anal atresia. Great. So those are the congenital malformations of the urinary system that I wanted to highlight to you. I don't know whether you have any question, you feel free to ask.